Hello and welcome to our review of the lupus literature from June. We record these podcasts for you every month, so you'll always be able to keep up to date on the latest literature and our opinions on it. I'm Ed Vitale, I'm the chair of the Lupus Forum. I work in the University of Leeds in the UK, and I'm joined today by Professor Vibeke Strand, who's Adjunct Clinical Professor at the Division of Immunology and Rheumatology at Stanford University School of Medicine in California. Welcome, Vibeke.
Why, thank you. Nice to see you.
So today we've chosen two papers from the journal issues that came out in June to be covered on the forum. They're both about biologics in SLE, and they're both kind of real-world evidence. So I'll just start taking us through the first one here, which is a paper about belimumab in lupus nephritis and predicting response. So this is done by Zhao et al. It's a group from Shanghai and some collaborating centers in China. So belimumab in lupus nephritis is a little bit newer than its use in non-renal SLE, but we know from its clinical trial that it adds benefit over and above what you see with the standard of care of mycophenolate or cyclophosphamide in terms of response and preventing relapses. But as always, there can be some quite big differences between real-world lupus patients and what you see in a trial. So, in a trial, the inclusion criteria can be stricter, e.g., you have to have quite recently active disease, recent biopsy. The standard of care is fixed. You can't really control it very much as an investigator, and that can mean that patients who've previously failed to respond to mycophenolate can't really go into a trial when mycophenolate was the standard of care. For example, people might have comorbidities, and these more homogeneous populations in a trial can also mean that it can sometimes be not such a great place to find predictors of response, maybe. So what they've done here is they've done a real-world observational study to look at their use of belimumab in lupus nephritis, and then they've added an investigation into predictors of response that had a kind of interesting finding. So 122 patients here, they included anyone who had 24-hour urine protein at least 1 gram and EGFR at least 30. Being treated with belimumab, but it could be in different stages of therapy. So 33 of the patients were new. A quarter of the patients had a new episode of lupus nephritis. 36 of them were adding belimumab within 3 months of a relapse. 53 of them were described as having belimumab because of inadequate response to other therapies. Other characteristics I thought were pretty typical. At age about 34, disease duration about 2 years. Follow-up in this study, average about a year, baseline protein about 3 grams, 42% nephrotic. There's 81 who had a biopsy result, and most of those were either class 3 or 4, 12% class 5, and 37% mixed. Background agents probably differed a bit from trials. About half the patients here were having background therapy of mycophenolate, 14% cyclophosphamide, 33% a calcium urine inhibitor. Interestingly, 13% were on no other immunosuppressants, just the belimumab. So looking at the response, you can see that on the screen there. So basically, overall, people were getting better here. So they've got definitions of response similar to those used in a variety of lupus nephritis trials, which vary a bit, but complete renal response meant 24-hour urine protein of less than 0.5 grams and EGFR more than 90, or stable if it was abnormal at baseline. Partial means 50% improvement in the protein with the same EGFR criterion. And then there's something called PERR, which is the primary efficacy response measure used in the lupus nephritis trial, which was defined a little bit more loosely as 24-hour urine protein less than 0.7, EGFR more than 60, or stable compared to baseline. and then non-response if you didn't meet those. So as you can see on the screen there, at 6 months, you got 36% of people with complete response and another 17 with partial. And at 12 months, that had gone up to 56% complete, 19% partial, with about 1/4 of the patients being classified as non-responders. Okay, so the efficacy seems quite good, at least, although with no comparator here, but the real world efficacy seems quite good. Then there's a novel bit here where they looked for predictors. So they found something a little bit interesting. They had a bit more data for 6 months than for 12 months because of people dropping out for various reasons. And that is kind of an interesting aspect that I kind of wanted to understand more about, why they were dropping out, because it might affect the findings. But basically what they could say was the 12-month response, 12-month non-response was predicted by 6-month non-response. Makes sense? 6-month non-response was predicted by, or 6 months response, put it this way, 6 months response was predicted by a positive double-stranded DNA, just like we see for non-renal lupus. It was predicted by having an EGFR more than 30, makes sense. But also it was predicted by being negative for Rho antibodies. In other words, whilst double-stranded DNA was associated with better response, Rho antibodies were associated with worse response. And then they looked at this combination of the two antibodies across the different categories of EGFR. And regardless of what your EGFR was, positive double-stranded DNA, negative for Rho, was the best response, which was kind of about 70 to 80% of patients. And the other way around, negative for double-stranded DNA and positive for Rho was the worst response, where it was more like 75% of people who were non-responders. So quite a big difference, with the other combinations being somewhere in between. So yeah, I thought that's something I hadn't really heard before. We don't usually hear so much about using other antibodies to predict biologic responses. The authors make a speculation that one thing we've seen recently, especially with some of these more intensive B-cell targeting therapies, is that Rho52 antibodies are the hardest to eliminate when you target B cells. Other ones go down, but Rho52 remains. So they're sort of speculating that maybe that's why it's associated with less good responses to belimumab, it's an interesting idea, although I think one has to be quite cautious about making causal statements from studies like this, because there's all sorts of things about who was included in the cohort. What about, people who got belimumab obviously had something wrong with their other response, and so maybe Rho positive people are doing something completely different in a broader population, etc., etc., etc. But still, I thought this was quite an interesting study. What did you think about it?
I thought it was interesting too. Of course, we've known about the double-stranded DNA and the low complements being the high activity population that generally responds better to belimumab, but actually generally outlines a more responsive population across lupus trials. So this is interesting, as you said, about the SSA or the Rho. I don't know whether that means that the autoreactome is different in terms of whether it includes double-stranded DNA or it doesn't, and does include Rho and La and autoantibodies, but we still have a lot to learn.
Yeah, that's right. And I also thought how, we always, in most biologic trials, we get quite a lot of data, usually something along the lines of positive double-stranded DNA, low complement. Those are they indicate activity and they associate with better response to drugs, or perhaps worse response to placebo, whichever way you want to describe it. But when we worked with rituximab years and years ago, when we first started with rituximab, there were quite a lot of data about how all these other antibodies were kind of telling you something important as well. And I often think when I'm in practice is that the reason these things are good biomarkers is because they tell me when people have got really active B cells, and therefore other biomarkers of B cell activity ought to make sense as well, but it probably needs a bit more work.
Yeah, that makes sense. I agree.
Should we go on to the next one?
Yes.
Okay, so you had a look at this study, didn't you, on telitacicept?
Yes. So this is Chang et al., and this is telitacicept, which targets APRIL and BAFF. and thereby inhibits plasma cells in terms of both proliferation and differentiation, so their survival. And we're looking at a small series of 22 patients. So telitacicept was developed in China and to date has been mostly studied in China. It's approved for treatment of lupus in China. And I believe they're finally doing a Western trial at the present time. But what the investigators of this series was looking at was to evaluate 22 lupus patients who had hematologic involvement. Now, this was a retrospective study, and as I mentioned already, only 22 patients, but it's some interesting findings because in general, we don't have a lot of hematologic manifestations included in our clinical trials when we're looking mostly for patients with musculoskeletal and mucocutaneous involvement, because that's the most highly seen in terms of active lupus, also in terms of scoring SLEDAIs and BILAGs. So these 17 of the 22 patients had anemia, 8 had thrombocytopenia, 14 had leukopenia, and 3 of them had cytopenias across red cells, white cells, and platelets, all 3 lineages. Now, the hematologic manifestations could be part of the underlying lupus. It could be associated with coexisting conditions or therapy. And so we don't necessarily know whether these are specifically lupus manifestations. But this is an interesting finding because we don't generally have a lot of data on hematologic manifestations in lupus from our trials. So all these patients received weekly sub-Q injections of telitacicept, either 60 milligrams or 180 milligrams, and duration of treatment was a mean of 10 months, ranging from 6 to 19 months. Again, these patients were about 36 years old. 77% of them had double-stranded DNA antibody positivity, and 82% of them had either low complement 3 or 4 levels. So these were active patients, and we have these clinical manifestations that generally aren't looked at so commonly. And what was seen was significant improvements in anemia, in low white count, and low platelets counts. And these were all statistically significant, p.002 for the white cells, less than 0.001 for hemoglobin, p less than or equal to p004 for platelet count. And the increase in both C3 or C4 was also statistically significant. Interesting, autoantibody levels did change. Anti-double-stranded DNA went down, but not statistically. But IgG and IgA levels did decrease and were statistically significant, indicating that there is certainly an effect on plasma cells. So the telitacicept in the 22 patients was well tolerated. There was only a single UTI that was reported. There were no SAEs or hypersensitivity reactions or injection site reactions. And the glucocorticoid doses were said to have been reduced, but no specific data on that. So I remind you that telitacicept has largely been studied in China and is only approved in China, but it's an interesting product. And we also know that there's another APRIL BAFF inhibitor in development, povetacicept. So what do you think, Ed?
Yeah, I thought, yeah, as you say, although the numbers here don't seem that huge, actually the numbers of patients with these hematological features in a standard phase 3 trial often aren't that huge either. And so it actually is quite meaningful information. Yeah, my only comment on this paper itself, I suppose, was that like you said, prednisolone doses were reasonably large at baseline. I think the average was about 30 something milligrams, and yeah, it came down at the same time that the patients responded, but of course that may have contributed a bit to the response as well. But still, this is adding to quite a body of evidence that's building around this therapy, isn't it? I mean, my other thought, though, when I read it, relates back to a discussion that you and I had in the clinical trials webinar that we did last week, which is that um, it's about the heterogeneity, capturing the heterogeneity of real-world lupus in a clinical trial, which is a challenge. And I understand why, when they do pivotal trials, there is this focus on a relatively homogeneous population, people who mostly have skin and joint involvement. But then also, when I give talks about new biologics and I present trial data, inevitably the clinicians in the room are always asking me, well, what about this really difficult patient I've got who's got like 3 other rare organs affected? And I always have to say, well, I don't know. And we don't really get that in clinical trials, and you'll have to look out for real world evidence to tell you what to do, which is what we're doing. But, it does always make me think, could we do trials that address these things more? Should we do trials that deliberately try and assess these other organ features a bit more explicitly?
Well, I think we could try, but I worry about, we have so much heterogeneity as it is. And now if we try to specifically cite certain organ system manifestations, we're going to have probably more heterogeneity. It'd be hard to look at comparability across patients. But the other issue will also be essentially, how can we accrue them? It takes long enough as it is now to accrue whatever we consider active disease population by BILAG or SLEDAI scores. And so I can imagine that this might be really challenging from a time frame point of view.
Yeah, but it would be. So I think you need to prioritize the organs that you're most interested in, don't you? Where there's the most need for evidence.
And that would certainly change the outcome measures.
And this is something that's kind of a post-licensing thing to do. Once
Yes,
we know the
yes.
drug's basically effective in the disease, we try and generate data a bit more on its uses. So, publishing small case series or case studies has gone very out of vogue in the literature, but can actually have quite an important role, can't it? And I sometimes wonder if we should standardize our collection of data a little bit more on some of these questions.
Yeah, and I think we should thank GSK for having done so many post-approval trials with belimumab, because we've learned quite a bit from them as well.
Yeah, and the national registries and things like that are all important as well, aren't they? Okay,
Yes.
well, that's all we've got time for today. So thank you very much for joining me, Vibeke. It's always great to hear your thoughts on the latest development in lupus management.
It's a pleasure. Thank you, Ed.
And thank you, everyone, for listening. As always, you can find the slide decks for these papers on lupus-forum.com. Lupus-forum is free to access. All the content is free for you to download and use in your own teaching or journal clubs. And don't forget to register for updates on the Lupus Forum. You'll get emails when new content becomes available, and you can follow us at Lupus Forum, or one word, on Twitter and LinkedIn. Thanks again, and see you next time.